everyone, and welcome back to Delta4 Studios. Or if you're new here, welcome. One of our experienced users, Francisco San Miguel from Hospital Gómez Ulla in Madrid, has put together a comprehensive presentation where he shares his team's clinical experience using Phantom Plus and our unique movement platform, HexaMotion. The presentation is divided in two parts. In the first section, Francisco provides a detailed overview of Phantom Plus, and in the second part, he covers the HexaMotion. If you're particularly interested in HexaMotion and how it's used to verify gating and tumor tracking, please feel free to jump directly to the chapter. We're always excited when our users share their experiences, and we hope that you enjoy this presentation. If you have any questions, please contact us at support@ScandiDos.com. And now, over to Francisco.
Hello, and welcome to this webinar. My name is Francisco San Miguel, and I am the head of the Medical Physics Department at Hospital Central de la Defensa Gómez Ulla. Our department is composed of 5 medical physicists and 4 technicians. We have 2 Elekta Versa HD Linacs operating in tandem with 6 MV without flattening filter, and 10 MV energies. Additionally, we have radiosurgery cones, the Elekta active breathing control system for deep inspiration breath hold treatments, and the Clarity system for prostate treatments. We also use the SGRT system, which is applied for deep inspiration breath hold treatments as well. Our treatment planning system for external radiotherapy is Monaco, and for record and verification purposes, we use Mosaic. Regarding treatments, we perform 3D conformal radiotherapy and VMAT using different fractionation protocols, SBRT in various locations, radiosurgery with and without stereotactic cones, and deep inspiration breath hold techniques. Today, I will share our experience using the Delta4 Plus system and the HexaMotion platform. So first of all, what is Delta4 Plus? Well, it is a high precision dosimetry system used in radiotherapy to verify treatment plans before they are delivered to patients. It is suitable for the measurement of IMRT and VMAT treatments, and it consists of a cylindrical phantom made of polymethyl methacrylate with 2 cross detector planes in plus-shaped geometry. Each detection plane contains an array of P-type silicon diode detectors arranged to capture a comprehensive 3D dose distribution with a distance between detectors of 5 mm in the central region, measuring 6 by 6 square centimeters, and 10 mm in the rest. The system has a user-friendly setup and easy workflow. It operates wirelessly via a Wi-Fi router and is compatible with all photon beam modalities, both with and without a flattening filter. All that is required is to calibrate each energy that will be measured. In conclusion, this design allows it to measure and compare the planned and actual doses, detecting any discrepancies with high spatial and dose resolution. So, to start measurements on the Linac, the first step is to calibrate the detector. This is very straightforward, and as can be seen in the first image, a farmer tape ionization chamber is inserted into the detector to measure the delivered dose and calibrate both detector arrays. As mentioned previously, this procedure has to be done with each energy used for treatments. On the other hand, it should be noted that the response of the diodes is deeply influenced by the temperature. Nevertheless, after initial calibration, Delta4 automatically applies temperature-based correction on each diode separately. The second image shows this temperature monitoring and the difference between each diode. With all this in mind, we obtained better results performing all measurements and calibrations after leaving the detector in the bunker where measurements will be taken for several hours beforehand. Additionally, the equipment allows corrections based on the daily Linac output and the detector positioning. In our clinic, we only apply positioning corrections when we know that the lasers are not properly aligned, and we never correct for the output since the patients are going to be treated with the daily output. Because the software reads the gantry angle on the decon plan, there is no need to correct for this, and of course, in order to be able to perform any gamma evaluation, we need to calculate the dose on the phantom in our treatment planning system. Since our scanner has the same couch as the Linac, a CT scan of the detector was made in order to include the couch on the treatment planning system calculations. On the other hand, depending on the dose calculation algorithm used to compute the dose in the phantom, it is recommended to override the phantom relative electron density to water with a specific value. If the treatment planning system used calculates dose to medium, ScandiDos recommends to override the relative electron density to 1.16. However, several publications have reported variability in the electron density of polymethyl methacrylate of the phantom compared to the standard value. According to our CT calibration curve, a relative electron density to water of 1.108 was obtained for the polymethyl methacrylate of the phantom. Obviously, the CT calibration curve used for patient dose calculations is generated with tissue equivalent materials, and deriving the electron density of polymethyl methacrylate from this curve involves a considerable degree of uncertainty. Taking this into account, a small study was performed for different treatments using both electron density values, and as can be seen in the tables, the results for the electron density value of 1.108 are even better, including for a 10 by 10 field. So based on these results, our routine practice for dose calculation in the phantom is to use the CT of the detector, including the treatment couch, and to override its electron density to 1.108. Since this is a detector used for treatment dose measurements, we perform a quality assurance procedure on it in our department. First, we carry out a daily take consisting of a 10 by 10 field at 45 degrees. In this test, we focus on two aspects. On one hand, we evaluate the dose correction factor by comparing it with the Linac's daily output measurements. That is, if the Linac dose is lower than the reference value, the Delta4 correction factor should be greater than 1. We also ensure that this value does not exceed 2% versus the treatment planning system value. We record this result for tracking and monitoring purposes, but we do not apply the correction on the measurement. On the other hand, since the 2% 2 millimeter gamma criterion is the standard in our center, we also verify that this criterion is met. The first image shows the result of the daily measurement performed for the 6MV flattening filter-free beam. As can be observed, the obtained daily correction factor is 1.0098. This means that the measured dose is 0.98% lower than the Delta4 reference value. The daily output measurement of the linear accelerator performed with a different detector was in this case 0.75% lower than the reference. So it can be seen, the result of the 2% 2 millimeter gamma analysis is 99.8%, and in addition, those profiles can be extracted from the measurement to verify that the PDD fall-off is as expected. Based on these results, the correct performance of the system has been verified and the device is ready for patient treatment measurements. If any discrepancies were observed in these results, we must investigate what is happening. Furthermore, once a month, we perform the same measurement but at 4 different gantry angles, taking into account the absorption of the treatment couch. The procedure is the same as in the previous case, but we add measurements at 3 additional gantry angles. In addition, if we have any doubts about the detector's performance, we measure several previously approved treatments and compare the current measurement with the approved one. Most of our treatments are VMAT, but we also deliver some 3D conformal treatments. We have measured both types of treatments with satisfactory results. As previously mentioned, our gamma criterion is 2% global 2 millimeter with 95% of the evaluated points less than or equal to 1. For normalization, the prescription dose is used. In cases where multiple volumes are treated simultaneously, the prescription dose of the largest volume is used, as we consider it to be more representative of the entire treatment. Additionally, the positioning of the measurement device can be adjusted for 2 purposes. First, after performing a measurement, the detector can be shifted longitudinally by 2.5 millimeter, and the same measurement can be repeated. The 2 resulting measurements are then merged, achieving a longitudinal spatial resolution of 2.5 millimeter in the central region of the detector. We mainly use this technique for SGRT treatments and very small volumes. The first image shows a case in which this technique has been used, and an improvement in spatial resolution can be clearly observed. Nevertheless, this technique can be performed using smaller displacements in order to improve the spatial resolution to the required level. The only drawback is that 1 measurement must be performed for each displacement. On the other hand, after performing the first measurement, the phantom can be shifted up to 90 millimeter in the longitudinal direction and measured again. Once more, the measurements are merged allowing treatment fields of up to 38 centimeters in the longitudinal direction to be measured. The second image shows a breast case in which this technique has been used with a total displacement of 60 millimeters. Finally, if after performing the measurement we observe any discrepancy and need to recalculate the dose in the treatment planning system, it is not necessary to measure again. The replanned dose is simply replaced and the software automatically recomputes the gamma values. Prior to the start of routine patient-specific QA measurements, the Delta4 system was validated by comparing its results with those obtained using other detectors already implemented and clinically validated in our department for radiotherapy treatment verification. As our department is equipped with the IBA stereotactic radiosurgery detector, a small comparative study was performed in which 10 SGRT treatment plans were measured using both systems. The SRS detector has a spatial resolution of 0.4 millimeters, which should be more than sufficient to accurately resolve steep dose gradients. So in this case, the figure shows the comparison for the plan exhibiting the largest discrepancies with respect to the treatment planning system. The measurement obtained with the Delta4 is shown on the left, while the SRS measurement is shown on the right. In the case of the Delta4, the double measurement technique was applied in order to improve spatial resolution. Leaving aside the gamma analysis results and the fact that the measurement geometries are not fully comparable, both systems show failing regions in approximately the same locations, highlighted in red in both cases. Furthermore, when analyzing the dose profiles, the discrepancies observed in regions with very steep dose gradients are remarkably similar for both detectors. In addition, our department has been performing dosimetry using the EPID panel of the Linac for several years, with very satisfactory results by means of an independent in-house developed software. In our specific case, the spatial resolution of the EPID corresponds to approximately 0.2 millimeters at isocenter, which should also be more than sufficient to accurately resolve those gradients. To ensure that the agreement observed in the comparison with the SRS detector was not coincidental, an additional comparison was performed between Delta4 measurements and EPID measurements. Once again, although the measurement geometries are not fully comparable, a very similar behavior is observed for both detectors. Again, the figure shows the comparison for the plan exhibiting the largest discrepancies with respect to the treatment planning system. The measurement obtained with the Delta4 is shown on the left, while the EPID measurement is shown on the right. And both systems, again, show failing regions in approximately the same locations. So based on these results, we can conclude that the Delta4 system is capable of detecting discrepancies in regions with high dose gradients and can therefore be considered validated for pretreatment quality assurance in our department. So this will summarize our routine use of the Delta4 Plus detector. On the other hand, there is an add-on for the Delta4 Plus called HexaMotion, which is a platform designed to support and integrate the Delta4 detector that enables translational movements along the X, Y, and Z axis and rotations around the tilt and roll axis, allowing these 5 coordinates to be varied as a function of time. With these 6 degrees of freedom, it is possible to simulate different motion patterns, such as stable, a drifting, or an erratic motion. And a respiratory-like motion can also be simulated. This platform is mounted together with the Delta4 to evaluate dose distribution while the detector is in motion. In addition, it includes a remote controller that allows movements along any axis and facilitates accurate centering of the device. So, in my particular case, the first thing that came to mind when seeing this platform in operation was whether it could be used to assess the robustness of the radiotherapy treatments we plan in our center under different conditions. For example, it would allow us to assess how different types of motion affect treatment delivery, that is, the interplay effect. We could also evaluate the robustness of treatment plans during deep inspiration breath hold, taking into account the radiation system's latencies. To begin with a simple case, the interplay effect was first evaluated in breast treatments. In this study, a total of 22 patients were assessed. The dose per fraction is 3.2 gray, and all treatment plans were generated using VMAT with bidirectional 180-degree arcs. Since, according to the guidelines, no interfraction motion management technique is required if the GDB moves less than 5 millimeters, a motion curve was created in HexaMotion to simulate breast motion due to respiration with a 4-second respiratory cycle and a maximum amplitude of 5 millimeters along the Z axis. Along the other 2 axes, the total motion amplitude was 1 millimeter. The simulated respiratory curve can be seen in the image with the green line representing the displacement along the Z-axis. Since this is the standard in our routine practice, the robustness study was performed using a global 2% 2 millimeter gamma analysis with at least 95% of points passing, normalized to the prescription dose, and comparing the static result with the result obtained when applying the simulated motion. As can be observed from the results, applying respiratory motion worsens the outcome, although not significantly. The mean gamma pass rate is 97.62% in the static case and 96% in the motion case. Furthermore, in some cases evaluated with HexaMotion, the global 2% 2 millimeter gamma analysis did not exceed 95% of the evaluated points, although when applying the global 3% 2 millimeter criterion, all plans exceeded the 95% threshold. The next study that was performed addressed the interplay effect in conventional lung treatments. In this case, a total of 21 patients were evaluated. The dose per fraction was 2 gray, and all treatment plans were generated using two 360-degree VMAT arcs. In addition, a more challenging respiratory motion scenario was deliberately applied. Specifically, a motion pattern typical of a lung tumor was simulated, with predominant displacement along the Y and Z axis. As can be seen, in this case, the largest displacement occurs along the Y-axis, represented by the red line in the image, with a maximum displacement of approximately 8 mm. Furthermore, the motion pattern is slightly irregular and includes a small drift along all three axes. According to the recommendations, in this case, some motion management technique should be applied. Nevertheless, in this study, we aim to analyze what would happen if no motion management technique were used. Once again, the study was performed using a global 2% 2 mm gamma analysis, comparing the static result with the result obtained when applying the simulated motion. In this case, applying motion leads to a more noticeable degradation of the results with increased dispersion of the values. As observed, the mean gamma pass rate for the cases with simulated motion does not exceed 93%. However, when applying a global 3% 2 mm gamma criterion, the mean value increases to 96.5%. So when the motion of the Linac leaves is combined with tumor motion, the interplay effect occurs. This effect leads to a blurring of the delivered dose, increasing it in some regions while decreasing it in others. In this first specific case, the first image shows the static measurement and the result of the 2% 2 mm gamma analysis. In the second image, the result of the measurement of the same plan can be observed while the detector is moving according to the motion pattern previously described. It can be seen how the interplay effect increases the measured dose in the treatment region. When analyzing another case measured with the same respiratory motion pattern, the opposite effect is observed. Again, the first image shows the static measurement and the result of the 2% 2 mm gamma analysis. And in the second image, the result of the measurement of the same plan can be observed while the detector is moving according to the motion pattern. In this case, the measured dose is lower than the calculated dose. This indicates that it is difficult to predict whether the measured dose under motion of the treatment region will be higher or lower than the dose calculated in the treatment planning system. Motion-related effects in other tumors, such as prostate cancer, can also be studied using HexaMotion. It is well known that prostate position during treatment is influenced by rectal activity, bladder filling, and involuntary muscle movements, which can result in different motion patterns in all directions. Based on the published literature, 4 different motion patterns were simulated, representing typical prostate motion observed during treatments monitored with Calypso and Radixact systems. The first model represents stable motion with a maximum amplitude of approximately 2 mm along the z-axis. The continuous drift model involves larger motion reaching up to 6 mm. The erratic motion the model is considerably more complex. The prostate moves along all 3 axes, includes a small drift component, and reaches displacements of up to 11 millimeters along the z-axis. And finally, the high-frequency model consists of brief displacements along the z-axis with an amplitude of approximately 12 millimeters, occurring at a frequency of about 70 seconds. In all 4 models, rotations were not considered, and as mentioned previously, although these models are based on published motion measurements, they represent theoretical motion curves. Since any of these patterns may occur during any fraction in any patient, all 4 models were evaluated for each analyzed patient. In total, 3 different patients were analyzed with a prescription dose of 70 gray delivered in 25 fractions, planned using a single 360-degree VMAT arc. For each patient, gamma analysis was evaluated for the 4 motion models and for each photon energy available in the department. And all the results were compared with the static case. As can be seen from the results, the values obtained for stable motion are essentially the same as those for the static case. For continuous drift motion, the results begin to deteriorate only in some cases. In contrast, for the erratic and high-frequency motion models, a clear and substantial degradation of the results were observed. The HexaMotion platform used in combination with the Delta4 can also be employed to evaluate gating and tracking techniques. Recently, our department has acquired the Catalyst surface guide radiotherapy system, which enables deep inspiration breath hold gating. In order to assess the reliability and effectiveness of this technique, a motion curve was designed to simulate a patient's respiratory pattern during a deep inspiration breath hold gated treatment. In this case, the largest displacement occurs along the z-axis with an amplitude of approximately 18 millimeters. In addition, as can be seen in the image, a slight drift was incorporated into the respiratory pattern to simulate patient fatigue during treatment. Within this context, 3 breast treatments, 3 lung treatments, and 3 SGRT treatments were compared. For each treatment, the gamma analysis results were compared for the static case, free breathing, and deep inspiration breath hold using Catalyst. And as can be observed from the results, the gamma analysis under free breathing conditions shows a slight degradation compared to the ideal static case. However, when applying deep inspiration breath hold gating, the results are very similar to the static case, confirming the reliability of this technique. So, to conclude, the main take-home message is that the Delta4 Plus has proven to be a robust and versatile dosimetric tool for patient-specific quality assurance in a wide range of radiotherapy treatments. Its use in routine clinical practice allows reliable verification of both conventional and advanced treatment techniques, including 3D conformal radiotherapy, VMAT, and SGRT. The system provides high reproducibility and stable performance over time, allowing consistent monitoring of delivery accuracy without the need for frequent recalibration. Daily and monthly quality control procedures can be implemented efficiently, ensuring confidence in the measured results while maintaining clinical workflow efficiency. The radiation measurement system based on P-type silicon detectors provides high dose resolution while offering adequate spatial resolution for most clinical cases. In summary, Delta4 Plus has shown good agreement between measured and planned dose distributions when evaluated using clinically relevant gamma criteria, such as 2% global 2 mm, which is the standard in our department. The system performs robustly for both simple and complex treatment plans, including cases with large field sizes and small target volumes. In addition, the flexibility of the Delta4 Plus system allows extended measurement capabilities through detector repositioning and data merging, improving longitudinal spatial resolution and enable the verification of long treatment fields when required. And for best practice, include the treatment couch in dose calculation whenever supported by your treatment planning system. Regarding the Delta4 Plus HexaMotion platform, it can be stated that it is a useful tool for evaluating the robustness of treatment plans against the interplay effect. This system allows the assessment of a wide variety of scenarios, such as breast treatments, lung treatments, including SBRT, and prostate treatments. Likewise, it enables the evaluation of the reliability and effectiveness of deep inspiration breath hold treatments using surface guide radiotherapy. On the other hand, the study performed for prostate patients suggests two possible considerations. The first is the need to reevaluate CTV to PTV margins, since depending on the motion pattern followed by the prostate during a given fraction, the actual delivered dose may differ significantly from the planned dose. The second consideration, and perhaps the most relevant one, is the potential need to apply motion correction techniques for all cases of this pathology. Naturally, several limitations apply to the studies presented. First, the Delta4 system is not a perfect surrogate for the patient. For example, in lung treatments, under real clinical conditions, the patient's sternal surface may move in one direction while the tumor moves in another direction with a different amplitude, whereas with the Delta4 and HexaMotion, the entire system is moved simultaneously. Besides, it would also be of great interest to include rotational components in future studies. In addition, all analyses were performed using generic theoretical motion curves, whereas ideally patient-specific motion curves should be used. In the case of breast treatments, for instance, motion curves could be obtained using the SGRT system, exported and introduced into HexaMotion. Another important limitation is that the clinical implication of the observed gamma analysis differences on patient anatomy remains unknown. Furthermore, for both prostate cases and deep inspiration breath-hold gating cases using SGRT, a larger number of cases must be analyzed to strengthen the conclusions. And finally, to conclude, the following references were used for all the studies presented. So thank you for your attention. I sincerely appreciate your time and interest, and best regards. Bye-bye.